Welcome back to my channel, guys. Today we are going to start osteosarcoma. So osteosarcoma is a part of mesenchymal tumors. Mesenchymal tumors has two parts: benign mesenchymal tumors and malignant mesenchymal. In malignant, we will learn osteosarcoma. It's a new topic. So this is how it presents in a radiograph. You can see the bone destruction over here. Yes. Can see how it's spreading and it's moving the teeth also. So let's learn about it. What is also known as is osteogenic sarcoma. So osteosarcoma is also known as osteogenic sarcoma. Now, as I told you, it is a malignancy of mesenchymal cells, right? So the definition also will be similar. Now, as the name suggests, osteosarcoma. Sarcoma, malignancy. Osteo is bone. So you will say it is a malignancy of mesenchymal cell that have the ability to produce either osteoid, okay. So osteoid, what is osteoid? It's immature bone. So what is osteosarcoma? It is the malignancy of the mesenchymal cells that have the ability to produce osteoid. Yes. Now we come to the cause. Now basically the cause is not known. The exact cause is not known, but it's said that it basically happens when there is rapid growth in the bone. Now, when do you think this will happen? This happens during the adolescent period. So, during the adolescent period, where there is growth spurt and there is growth in the metaphyseal plane of the long bones, patients are more predisposed to developing osteosarcoma. So this is one reason they have given for the cause. Second is environmental risk factors. So there could be radiation. So either after a radiation therapy also, people might develop osteosarcoma. And the third cause is genetic predisposition. Now in genetic predisposition, there is four things to remember. Not four factors, what am I saying? Four things to remember. First is familial cause. So this, just remember, once you know osteosarcoma in genetic, there will be four causes. The first cause will be familial. In the familial, there will be deletion of 13q14. Just remember 13q14. I told you in the first video how to say this. 13q14 you have to remember. 13q14 for osteosarcoma, deletion of this. So deletion of this chromosome, gene, will result into inactivation of the retinoblastoma gene. Okay, inactivation of the retinoblastoma gene. Now this retinoblastoma gene, if it is inactivated, retinoblastoma gene, there will be retinoblastoma. Okay. So what is retinoblastoma? I will just show you. This is a healthy eye. This is a eye with retinoblastoma. So here you will see tumor forming. Yes. So this retinoblastoma gene, if it's deleted, that the patient is more predisposed to osteosarcoma. So there is this patient is at a higher risk of forming osteosarcoma. Second, genetic predisposition we are learning. Second is bone dysplasia. If you have some Paget's disease, fibrous dysplasia, enchondromatosis, and hereditary multiple exostosis. So if you are previously you had any of these, then you are predisposed to osteosarcoma. You have to write this. Then is third one. We are the four causes. We are learning the fourth genetic predisposition. We are learning the third one. That is Lee-Fraumeni syndrome. Lee-Fraumeni syndrome. This, in Lee-Fraumeni syndrome, there is germline P53 mutation. Okay. So this P53 mutation, due to P53, remember P53 in Lee-Fraumeni P53. So there is sarcoma. These are the things which are affected. Sarcoma of the blood vessels, nerves, musculoskeleton, adipose tissue, breast, lymph, leukemia, adrenals. Okay, all of these. So there is sarcoma in most of the list which I have mentioned over here in Li-Fraumeni syndrome. This will be the third genetic predisposition. And fourth will be your Rothmund-Thomson syndrome, which is autosomal recessive. Okay, recessive it is. So what happens here? There is congenital bone defect in Rothmund-Thomson syndrome. Congenital bone defect. Bone defect will again predispose to osteosarcoma. Then there will be hair and skin dysplasia. Okay, very scarce hair and skin. There will be flaking and all. Then there is hypogonadism. Hypogonadism, gonads are not well fully developed, and then there could be cataract also. So this is a photo of Rothmund syndrome where you can see the arm is not fully formed, right? These are the this is etiopathogenesis. The exact cause is not known, but we know that it happens during rapid growth. That's one. Then the second will be environmental risk, radiation. The third is genetic predisposition, in which we learn about 4. It's familial cause 13q14. Then you have your second, which is bone dysplasia. Third is your Li-Fraumeni syndrome, and fourth is your Rothmund-Thomson syndrome, which is autosomal recessive. Next, we go on to the clinical features. What do you think you will see in osteosarcoma? First, we go to see the sites. As we said, metaphyseal bone. So we go to see the metaphyseal plate in the long bones, femur, tibia, humerus, skull also can be involved, jaw can be involved. Here I have put a photo because we are interested in jaw, so obviously jaw is involved, that's why we are surrounding it. Then pelvis could also be involved. Then in maxilla, what are the areas which are affected most? It's the alveolar ridge and the maxillary sinus. This is the areas, alveolar ridge and the maxillary sinus are affected in osteosarcoma. In mandible, it could be the body, it could be the symphysis, the angle and the ramus and the TMJ. The most living alveolus, everything is affected. You are saying. Then what will be the symptoms? The patient will come to you with pain and swelling, either in the TMJ or in the sinus or in the alveolar ridge of the maxilla, in the body, or the angle. So all of these sites which I have told you. And there could be history of trauma also. History of trauma could be given. So you have to take a proper history to know that there was a history of trauma which has led to osteosarcoma. Then there will be other symptoms like sprain, arthritis could be there, and the word which they use in osteosarcoma is known as growing pain. Like they will say that the pain has increased over a period of time. The growing pain is to be remembered. It's to be remembered. For Viva they will ask, I don't know. If you don't see my video, you will not answer. So growing pain you have to remember. Then other systemic symptoms are similar systemic symptoms, same, that fever, fatigue, weight loss, swelling, pain, bone fracture, everything. So that you have to say if they ask you the symptoms. I have put this photo. So I have written over here. Yes. And then there could be regional lymphadenopathy, but it's rare. Lymphadenopathy. No, it's lymphadenopathy. Now we come to our main topic, where we have to focus. Oral manifestations. So oral manifestation, what you will see? You will see swelling first of all. I have told you swelling will be there from the start. Pain also will be there. So if there is swelling over here, obviously there will be facial asymmetry. So there could be toothache, there could be mobility because it's growing so fast, rapid it is. Yeah, any malignancy, rapid. So there will be the roots moving, which causes the tooth to move. Exfoliation, falling out of the tooth, bleeding because the blood vessels cannot accommodate such rapid fast growth of the cells and they start bleeding. Then you have the nasal obstruction. So the tumor could come in the way of the air, airway, the passage of the airway, which could lead to nasal obstruction, dyspnea. And males are more predominantly affected than the females. There is a predilection seen, and the average age for a person is 27. The mandible is more affected. Mandible is more bone, more more bone, compact bone, no? So mandible is more affected than the maxilla. Okay. And there could be history of trauma. I told you history of trauma. You have to remember. So there are some variants of osteosarcoma. When I say some, it's not some. It's a lot. Here I have put photos, I did not show you. So this is the oral manifestation. Here you will see this swelling. Look at this swelling. This swelling has caused exfoliation of this teeth. I cannot see even the teeth. So here you have another swelling. And then see here. Look at this swelling. Look, the teeth have also been moved backwards from here. And this is the radiograph of that. Okay, now we come to the types, variants. So first you remember conventional. Conventional is most common. 80 to 60% of all cases conventional. But conventional has further subtypes. It has 3 subtypes. Remember, osteoblastic, chondroblastic and fibroblastic. As the name suggests, osteoblastic will have osteoid production, chondroblastic contains cartilage and fibroblastic will have fibrous tissue. Simple. So conventional has 3 subtypes: osteoblastic, chondroblastic, fibroblastic. Osteoblastic will have osteoid tissue, chondroblastic will have cartilage production, and last one is fibroblastic. Fibroblastic will have fibrous tissue component. Simple. Now we go to telangiectic type of osteosarcoma. This is a very rare. So telangiectic, where you see telangiectic? Telangiectic, you remember vessels. So it mimics aneurysmal bone cyst. So there are blood-filled cavities. Aneurysmal bone cyst, we have drawn the diagram on the journal where you draw red. Same thing. So here there are blood-filled cavities into the bone. The histo, if you go to see the histo, obviously blood-filled cystic places with malignant cells that produce osteoid. So there is osteoid plus there are these blood-filled places. It could be hemorrhagic. So since there is blood, it's hemorrhagic, and there could be necrotic areas. Some like if there is blood which is spilling out like this, the macrophages will come, try to remove all the debris, and will cause necrotic area. Right? Simple. So this is telangiectics osteosarcoma. Now we come to small cell osteosarcoma. Small cell osteosarcoma is not very common. Like telangiectic osteosarcoma is also very rare. Small cell osteosarcoma is also uncommon. But remember, it's an aggressive variant. Small cell, it's very aggressive. Similar to Ewing sarcoma. Ewing sarcoma we will do soon enough. Or lymphoma pattern under microscope what produces osteoid. So it has lymphoma or sarcoma, Ewing sarcoma or lymphoma pattern, which we will learn later. But it produces osteoid. Small cell osteosarcoma. So in histopath, if you see, there are small round ovoid malignant cells, same as the Ewing sarcoma or lymphoma, that cells, similar cells with focal osteoid formation. So there are focal, in certain areas only there is osteoid formation, and the prognosis is very poor. Why do you think very poor? Because aggressive, it will finish it off. Okay. So how many types we have learned? Conventional, under conventional 3. You remember now? 1, 2, 3. Yes. And then telangiectic osteosarcoma and then small cell osteosarcoma. Now we come to the 4th one, that is parosteal osteosarcoma. Parosteal. Juxtacortical also, it says we got juxtacortical on the surface. Okay. So this is a very low grade variant. So it's not aggressive. Okay. Arising from the surface periosteum. So there is a long bone from the surface periosteum. It arises from there. Slow growth it is. Okay. And if you talk about the histopathology, it's very well differentiated. Fibroosseous tissue units. Fibers everywhere and osseous, osteoid. Fibroosseous tissue. When you learn fibroosseous lesions, we will learn about fibroosseous tissue also. Okay, we have a whole chapter about it. Next we come to periosteal. Now perosteal and periosteal. Perosteal, periosteal. Okay, this one is perosteal, this one is periosteal. So in periosteal, it's an aggressive variant of perosteal. Why don't I put this line? Sorry. Okay, so periosteal is a aggressive variant of perosteal. Okay, what will you see in the histopathology? You will see chondroblastic differentiation with some osteoid formation. So in perosteal, you saw it was a low grade variant, not that aggressive, good prognosis. Why? Fibrous tissue you could see. But here in periosteal, which is a very aggressive version of perosteal, you will see chondroid tissue formation with some chondroblastic differentiation with some osteoid formation. So you have chondroid, cartilage plus osteoid. Danger. It's very poor prognosis. Now we come to high grade surface osteosarcoma. High grade, again aggressive. They will be rare. It is very rare. It is aggressive and occurs on bone surface. Obviously, its name only suggests high grade surface osteosarcoma. So in the surface and then partially mineralized. Okay, it is partially mineralized, but this will also be very poor prognosis. Now we come to low grade, which is rare, low grade central osteosarcoma. Central, all these times we were surface. Now we come to inside, medullary cavity. From the central part of the bone, there is a medullary cavity. What you will see, well differentiated fibro-osseous tissue. Where else could you see fibro-osseous tissue? In the perosteal, right? Good prognosis, fibro-osseous, good prognosis. Then we come to extramedullary osteosarcoma. Extramedullary will be extremely rare, that occurs in the soft tissue directly, not bone. Leave bone. They said, I don't want to deal with bone. So it occurs in the soft tissue. What are the ones which are affected is the breast, the liver, the kidney, and they represent malignant teratome. Now we come to radiographic features. Before the radiographic features, let's revise. What are the types? First is the conventional, which has 3 types. That is osteoblastic, chondroblastic, and fibroblastic. Yes. Then is telangiectatic osteosarcoma. Then is small cell osteosarcoma. Then is perosteal osteosarcoma, periosteal, high grade surface, and low grade surface. No. Low grade central, low grade not surface, low grade central, and then you have extramedullary. Finished. These were the variants. Okay. Now we come to the radiographic features. Radiographic features, it's variable appearance. Okay, depends on the amount of tumor bone synthesized by malignant osteoblasts. Okay. Depends on the amount of tumor bone. So either it could be little tumor bone, little osteoid, radiolucent. It could be intermediate. It will be mixed radiolucent, radioopaque, and then it could be more tumor bone, that is radiolucence. Sorry, radiodense. Okay, radiolucent, mixed, and radiodense. So you have to remember this particular word for viva. What? Cumulus cloud densities. Look at this picture over there. This is what is called as cumulus cloud. This you have to remember. It's a very pathognomic sign of osteosarcoma. Cumulus cloud densities from within the, I'll move away, intramedullary and soft tissue compartment. So within the intramedullary and soft tissue compartment caused by mineralized tumor osteoid. So the osteoid tumor which is formed laid down by the malignant mesenchymal cells have been mineralized, and this causes your cumulus cloud appearance. Okay. Now there are 3 classic features which you have to remember also. 3 classic features will have 3 separate names which you have to remember. I will put stress on this. So small streaks of bone that radiate outward from approx 25% of tumor. Okay, there are small rays which radiate outwards. So these rays which radiate outwards are known as, what are they known as? They are known as sun ray appearance or sunburst appearance. Look at this one. Can you appreciate it? Like, I have taken mehnat to search this. Okay, this is sun ray appearance 1. The second one is tumor may grow within the PDL space and they will increase the widen the PDL space. Okay, there is a scene widening of the PDL space here in this photo. Can you appreciate this one? Widening of the PDL space. This has a name also. So this one is known as, Garrington sign, and this one sunburst, I have to say. Garrington sign, remember, that is widening of the PDL space. Garrington sign, sun ray or sunburst appearance, and cumulus cloud also you have to remember. Then long bones, the periosteum is elevated, so the long bones are there now. So they have their periosteum just beneath, just adjacent to them. They become elevated and they form a tent-like fashion which is known as Cordman's triangle. This one also you have to remember, Cordman's triangle. So these are the terms you have to remember. So let me show you. Can you see this? Do you see this tent-like fashion is your Cordman's triangle. Now we come to histopath. Let's finish it fast because I have 14% left. Okay, sorry. So histopath, osteoblastic, you see 60% proliferation of atypical pleomorphic osteoblast in stoma. When I say osteoblastic, 60% is the conventional osteoblastic, conventional type which we have learned, 3 types: osteoblastic, chondroblastic, fibroblastic. In that osteoblastic, there are 60% of the cases which are osteoblastic. Okay, so you see proliferation of osteoblasts in the stoma and the tumor osteoid formation, lacunae containing cells, and then there is, these all are disorderly arranged and irregular margin. As you see in this, there is a very irregular margin of the osteoid bone. All of these are osteoblastic cells which are in a rim-like fashion around the osteoid bone. If you remember that rim-like fashion, I have not written but I remember. Okay. And fibroblastic, it's 34% proliferation of anaplastic. This is the slide which they will show you in your practicals. Fibroblastic will not be there, most probably. Fibroblast I have written. Fibroblastic is 34%, so proliferation of anaplastic fibroblast. As here you had pleomorphic osteoblast, here you have anaplastic fibroblast, and they are very scarce tumor osteoid. Very scarce, there will be tumor osteoid. And in chondroblastic, you will have neoplastic means myxomatous chondroid tissue, myxomatous, a lot of myxoid tissue, and cartilage which will be of limited amount, tumor osteoid. Plus you could see osteoblasts, okay, in chondroblastic osteosarcoma. What you will see? You will see myxomatous chondroid tissue plus cartilage is very limited, plus you will see osteoid and osteoblast. Osteoid and osteoblast are main, you will see everywhere. Then this is Inacking MSTS staging system of osteosarcoma. I don't know if the name I just pronounced is correct or not, but it's Inacking. Stage 1 is low grade, no metastasis. Low grade, no metastasis. So you have 1A, 1B in stage 1. 1A is intra-compartment into the compartment. 1B is extra-compartment, side compartment. Easy to remember. Low grade, no metastasis. Grade 3 is high grade, no metastasis. High grade, no metastasis, again intra-compartment, extra-compartment, easy, 2A, 2B. Then is stage 3, which is low or high grade, but with metastasis. It does not have intra-compartment or extra-compartment because it has mets. Now, if we talk about the treatment and prognosis, For long bones, you will probably go for amputation. For other sides, you can have radial resection. You will learn about radial resection in surgery, the neck dissection or something. And you can have chemotherapy also as an option. The 5-year survival rate after an osteosarcoma is 63%. With that, we finish with osteosarcoma. Thank you for a patient hearing.